Welcome to the second parallel session, which is about health financing. My name is Abdullah Gujjar, and I'll be hosting this session. There will be 3 talks of 40 minutes each. There would be 10 minutes Q&A section at the end of each talk. You can ask questions in Q&A section, but if you want to coordinate or talk with the rest of the participants, you can leave your comments in the chat box. I will now hand over the mic to the co-chair, Dr. Shafiq Gill. He is a consultant histopathologist and clinical chair, diagnostics and outpatient division at Sherwood Forest Hospital's NHS Foundation Trust. Over to you, Dr. Gill.
Thank you, Abdullah. Good morning and assalamu alaikum, everybody. Welcome to the 3rd Universal Healthcare Symposium of ChemCA UK in collaboration with KEMU and ChemCANA. I would like to introduce my other co-chair, Professor Asghar Naqi, who does not need an introduction because you all know him. He is chair of Department of Surgery at King Edward Medical University, Dean Allied Health Sciences and Director Postgraduate Studies. And our chair for this session is Professor Mahmood Adil. He is a medical director at Public Health Scotland, and he is an experienced healthcare professional with about 25 years experience in executive management, in policy and research areas, and he is chairing our session today. Over to you, Professor Mahmood Adil.
Thank you, Gil. It's so nice to be over here. Are you happy for me to start my presentation?
Yes, please.
Yes, please go ahead.
Can you see my first slide?
Yes, we can see your slide.
Yes, we can.
Okay. Very good morning from Manchester, UK, and Assalamu alaikum. So I'm so pleased that we are having this session because the finances are going to be very critical for any healthcare system. So I have been tasked by ChemCANA that I should talk about financing of NHS in UK. So of course I've been living in UK for the last 30 years and part and parcel of the NHS. And of course I spent some time in America. So I have given this talk at the topic, health is wealth. It is very important that we need to remember that when we invest in health, it has got the best return on investment, and I will talk about it later. So as Shafiq mentioned, I'm medical director at Public Health Scotland. But before that, I was National Quality and Efficiency Advisor to the government at Department of Health for England. So maybe some of my experience, which I learned by being part of the Department of Health and advising number 10, I'm just going to share with you. So let's start. What are going to be the aims of this 30-minute session? And I will take some questions and answers at the end. So the first, to understand the basics of financing health system in any health system, but in this case, in the NHS context. Then to explain the NHS finances in England, allocation, flow, impact, and regulation. The reason I am saying England, because as people know, the United Kingdom is consisted of 4 nations, and the health is a devolved function to all. So basically all 4 nations, England, Scotland, Wales, and Northern Ireland, they have their own health budgets and they decide about their own health policies. But it is similar to Pakistan, where the health is a devolved function to all the provinces. So there are some commonalities between the UK and Pakistan. And then finally, to discuss the ideas and any suggestions to innovate financing models in Pakistan health system. And the ultimate goal should be that we should achieve better outcomes with fewer resources. And that is applicable to any health system, but in particular to Pakistan. So let's start with context. So any health system has got 6 elements, and these are the elements decided by WHO. And I'm sure many of you know these. First of all, we need to have a management and governance system. We need to have financing, service infrastructure, the hospitals and everything else, human resources, the staff, inventory and technology, and the information and data. So these are the 6 pillars of any health system. Today, we are going to talk about financing. So the purpose of any health system is that it should meet the health needs of the population. And the health needs mean it should be able to deliver health protection as we are in the midst of COVID-19. So it has become pertinent for any health system, and rather health protection has become paramount. And it has exposed many countries where they did not have or they don't have a good health protection. So then health promotion, it means we need to promote good health and looking at the population behavior. And the third one is the healthcare. Delivering the healthcare means that dealing with the physical, mental, and social well-being of the population and patients. But ultimate goal is longer, healthy lives. And I think we need to remember this goal, because whatever we invest in and whatever we do, we need to be achieving that goal, that longer, healthy lives. For example, the life expectancy of UK is almost 80 years. And I think, and most of those years are healthy. Maybe last 10 to 12 years are not as healthy. But if you compare with Pakistan, the life expectancy is much less. And then people are living, most of their years are not healthy years. So what are the challenges? So we need to be thinking challenges in terms of needs versus resources. So the challenges come from chronic diseases, elderly population, new technologies and drugs, and health inequalities. Let's start from chronic diseases. When the NHS was established in 1948, only 20% of our beds were filled with patients with chronic diseases. Now, 70% of our beds are filled with patients with chronic diseases. And this is the case all across the globe, looking at diabetes, cancer, stroke, CVD problems. We can think about that why they are on the rise, and then why our health systems, they need to think about dealing with chronic diseases. And it means that our investment should be on the prevention and the primary care side rather than secondary care side, because secondary care is pretty good in dealing with acute challenges. Second thing is about elderly population. So at times we have become the victim of our own successes. As the medical knowledge has improved, people are living longer, but when people live longer, there are more chances the last 10 to 15 years of their life, they might have more comorbidities. So 80% of the UK population is over 65, and almost 3% of our population is over 90, over 85. So we need to be thinking that what are their needs? For example, dementia is becoming very, very common problem where the countries where people are living longer. And if you look at Sweden, Japan, Italy, Spain, these are the countries who have got the highest longevities. So they do have similar challenges like UK. Then the third thing is new technologies and drugs. I think the example is pretty evident. Look at the COVID vaccine. So if you think about new technologies and drugs, they are all the time coming. And every health system needs to be thinking how best they can take up those technologies, but that does cost. And it means we need to be having a good balance, taking up new technologies and thinking about what we need, what we can drop. Last but not least is health inequalities. And again, I think we need to be careful that when we look at the population health or health of a country, health of a nation, we need to be thinking that we cannot increasing the gap between the people who have got better health and between the people who have got worse health. Because sometimes health systems do invest, but that investment is going to benefit the people who already have got good health. It means the gap will increase, and this is health inequalities. In the UK NHS, this is one of the key challenges that we are very keen to deal with, because we are not only one of the best healthcare system in the world, but we are also keen that our gap in health inequality should narrow. So of course, I oversee Scotland, And Scotland has got one of the biggest health inequalities within UK. But of course, in England, in Wales, and in Northern Ireland, we have got health inequality. Then just very basic, I do not want to spend more time on this, but if you think about funding models all across the globe, we can basically put them under 4 domains: the Beveridge model, the Bismarck, the National Health Insurance model, and out-of-pocket model. The Beveridge model is, which is based on, it is everything, it is a universal health system, everything is covered by the government. Bismarck model is that it is based on the insurance which is coming from the people and the employer, the people who are working and the employer who are contributing to it. And the National Health Insurance model, it is a mix of the Beveridge and Bismarck, and the out-of-pocket model, that there is no model and people are paying from their own pocket. I think there is some background noise. If people and my colleagues, they can put their microphones on mute, please. The out-of-pocket model is a good example that there are about 200 countries in the world, and only 40 countries, they do have some sort of system. The remaining 160 countries, they are actually don't have a system, and that is the people are dealing with out-of-pocket model. And I think that is where the biggest health inequalities across the globe. If we talk about 7.5 billion people, then I think we are not in the NHS in UK, colleagues in America, and everyone else, our colleagues, wherever they are working, they need to be thinking what best we can do for the whole world, rather than thinking about the country where we are. But talking about Pakistan, it can become a good model to many countries, provided it can chart out its path very clearly. And of course, at the end of this session, we can talk about it. So very, very briefly, the key difference between Bismarck and Beveridge, I think William Beveridge, who was the man who gave the model and in 1948 to establish or the model for the NHS. So if you look at the key difference between Bismarck and Beveridge, the entitlement basis, only those people are entitled in Bismarck who are paying and who have got the insurance. In Beveridge, all the citizens are covered. Funding base is wages, means that the people who are employed and the employers, and the Beveridge is all public revenues. Insurer is basically based on the people where they are working, and the Beveridge is the state is responsible. Benefit package, in Bismarck, it is explicit. In Beveridge model, it is implicit. So it is the government policy which decide, and there's certain things which are not decided, and then it means it is implicit. For example, people do say there is implicit rationing in the countries where there are Beveridge model. Management, it is independent in Bismarck, and Beveridge, the government is responsible for management. Providers in Bismarck, most of the time it is private healthcare, and then in Beveridge, it is the public sector. And the Americans are much more closer to Bismarck, and the UK is much closer to Beveridge. Nowadays, there is no pure either Bismarck or Beveridge. Maybe NHS is leading the light on Beveridge front. So now we started on NHS. Let me give you a very, very brief introduction of the National Health Service. It was established on 5th of July, 1948. And Nye Bevan, who was the founder, he was a Welshman, he was a Minister of Health at that point in time, and he thought that the country, the nation, they need to come up with a model and with a service which should stick to those fundamental human right principles. The first one is the universal health care. Second, free at the point of delivery. Third, it should be based on clinical needs, not on your ability to pay. And then every citizen should be registered with GP. So at that point in time in 1948 or even before, there were general practitioners, but the people were paying from their pocket to go and see those general practitioners. What Nye Bevan suggested, and I think the leaflet on the right-hand side is the original photograph of the leaflet which was distributed on that day to the whole public that the new health service has born. And it says that you must register with the general practitioner. So the NHS is based on those fundamental 4 principles. But if you ask that what is the purpose of the NHS, it is actually to improve the health outcome of the nation. So it is not to provide the service, but to improve the health outcome. And I gave you an example already. The health outcome could be how many years people live, what is the quality of their life. And this is the health outcome which NHS has improved in the last 72 years. So, but at the same time, in the last 72 years, the National Health Service started facing many challenges. And I have already mentioned to you about 70% of our beds are covered with chronic diseases, and that is where our budget is being spent. Here's a good example. The childhood obesity is becoming one of the challenges, but where the childhood obesity is, that is a good map, and the power of data, the number of fast food outlets per 1,000 population. The darker the color is, the more fast food outlets are. And many of those outlets are within 500 meters of the school range. So this is a good example which shows that if you want to deal with, if you want to spend our budget at the right place, then we need to be looking at where those diseases are coming from. So in the NHS, as the word is health, not healthcare. So the NHS acronym stands for National Health Service, not National Healthcare Services. And it is a big debate all the time in our country that we say health versus healthcare. And the question is, if we have got a budget, which I'm going to show you later, where that budget is being spent, going to build more hospitals or going to work upstream. Here's a good example. If you want to deal with the childhood obesity, it means we can deal with the diabetes down the line. And that is the way we are trying to deal with the challenges and trying to spend our resources. Here is the diabetes map. And again, it is a good example. On the left-hand side, the state of diabetes in England in 2005, because it is lighter, means it is almost about 2 to 3% of our population have the diabetes. If you go to the right-hand side, it is the projected map for 2015. And you can see that most of the areas of England is dark brown color. And it means almost over 7% of our population is going to have diabetes. So, and diabetes leads to many other problems. And many of you who are frontline clinicians, and you can see even in COVID, we have started seeing the patient with diabetes, they took the highest resource because they were staying longer, they have got other complications along with other chronic diseases. So that is again a question that, and by the way, at the moment we are spending 12% of our total budget on diabetes, and that includes the direct care for diabetic patients. So this is again a point I'm trying to make, that when we talk about money and resources in any health system, we need to be thinking what is the burden of disease and where the money is being spent. So let me move into the second part of my presentation about NHS funding, or health is wealth. Let me explain that why we are saying health is wealth. Well, first, the countries who are pretty effective in order to deal with their health challenges, they see the funding, health system funding, as an investment, not the cost. Because if you see it as a cost and you are sitting around the Prime Minister and trying to fight for your corner to get the budget, then other parties will see it as a cost. But in the NHS in the UK, it is being seen as an investment. So if you make an investment in health, the more the investment, more your nation is, people don't have, and they're physically fit. If they're physically fit, then the nation's productivity goes high. When the nation's productivity goes high, their GDP goes high. And this is the notion behind health as well. The second thing is that when the health system is strong in any nation, that health system also generates a lot of resources, income. And that is a good example because R&D is a very, very powerful tool in America. And R&D is very, very powerful. Research and development is very powerful in UK. And that's the reason if you look at the top 2-3 COVID vaccines, they're being developed either in the UK or they're being developed in USA. So it means that it is again, health is wealth because the health system can generate a lot of resources. Right. So let's start from what is the state of play about the UK budget. I have showed you where the income is coming. That is the pink bar on the left-hand side. And I'm showing you where that income is being spent. So if you look at the budget, it is £130 billion. That is the health budget. Interestingly, if you look at where the money is being spent, it is the highest spent after 214 billion, which is smaller projects. So health, as I said, health is wealth, where that England is spending 130 billion. And again, if you look at defense, it is only 28 billion, and defense is a centralized function. So this is the defense budget of the United Kingdom. So this is, you can see that the maximum amount is being spent on health. And if you look at where the money is coming, 339 billion is coming from income tax, and there are a lot of other. So total budget is 841 billion, and then our spend is 841 billion. And out of those, 130 billion are being spent on health in England. And that is almost about 9% of the GDP and the 18% of the total budget. And you might ask that where the money, what is the health funding for Scotland, Wales, and Northern Ireland, as it is a devolved function. And if you look at the bottom, the part of that graph, the blue one, 214 billion, that money is being distributed to all three other nations, and then they spend their money the way they like on health. So NHS principles are the same in all the 4 countries, but the way the NHS is run is different in those 4 countries. So now, because I'm talking about England, because England is the biggest country, almost 58 million people, I'm using it as an example. So this is England health budget over the years. So in 2008 and 9, it has almost 118 billion. Now we are in 2021, it had 149 billion pound budget, but 51 billion has been added, that pink bar, for COVID. So it is a big chunk of money being added to deal with COVID. And of course, it is a wealthy, rich country and it can afford. But again, the notion is health is wealth. If we can save the nation from COVID calamity, it means that we can bring the nation back on their feet and they can start producing the GDP as it is expected over the years. And again, next year, the budget is 160 billion, and that is the total UK budget, the total England budget. And then again, 20 billion has been added for COVID. It is very important to understand the structure of the NHS when we see that how the money is being distributed. So NHS in England has got a key, the main organization is NHS England, NHS Improvement. Now they have been merged, and if I use the simple word NHS England, it is an organization which oversees the whole country and all system. There are 135 clinical commissioning groups. When we started this reform in 2013-14, there were 211 clinical commissioning groups. Now there are 135. Basically, in England, all the organizations can be divided into 2 groups, commissioners and providers. And I will define what commissioners are and what providers are. So the NHS England and the clinical commissioning groups are the commissioners. And then the other 3 organizations, the local authorities, 151, NHS trusts, which are all the hospitals, and then the about primary care networks, which consisted of almost 7,000 general practices, they all are providers. So the difference between commissioner and providers are, the commissioning is basically purchasing, but it's a very clear definition we have agreed. Commissioning is the process of planning, agreeing, and monitoring health services to ensure that they are provided effectively, that they are effectively meeting the need of the given population. So the emphasis is on providing the need of the effectively meeting the need with the budget you have given. And the two main organizations who have been given this task to do the commissioning work is the Clinical Commissioning Group 135 and NHS England. And then there are providers. These are the organizations who provide secondary, community, ambulance, public health, mental health, and primary care services. There are NHS Trust, there are 77. Then we have got NHS Foundation Trust. The main difference between NHS Trust and NHS Foundation Trust are that NHS Foundation Trust are autonomous financially. So they can generate their own money and then they can spend. So they've been given the money, but they can also generate their own resources and they can spend their own resources, but they're accountable. NHS Trust, they can't generate their own resources. Then we have got Public Health England, which is responsible for public health functions. We have got local authorities, which are providing a lot of public health functions. And of course, we have got almost 7,000 GP practices, which are responsible for primary care services. And these are the roles. The clinical commissioning groups are responsible for urgent and emergency care. They are responsible buying elective hospital care. They are responsible to buy community health services. NHS England, although they are also commissioning services. They are commissioning specialist services, which are rare diseases like renal nephrology, a certain type of cancers, and that they are also responsible for secure mental health services, military services, and then there are military and veteran healthcare, prison healthcare, some public health services, for example, immunization. So the COVID vaccine is directly being paid by the NHS England. And then they are providing that services through all the general practitioners. So they are not asking the clinical commissioning group to deal with the COVID vaccine. Just trying to give you an example. The same apply to a number of other immunization. Primary care services, for example, NHS England directly pay for the dental services, pharmacist services, and the clinical commissioning group, they don't pay for that. And then the local care through the clinical commissioning groups. Now, this is about the funding flow. And if you look at the Department of Health and Social Care is a ministerial department. When I was working in Department of Health till 2014, I was a national advisor. At that point in time, the Department of Health was also planning and the services and also giving money directly. Then 2014, basically the Parliament gave money to Department of Health, almost 138 billion pound in 2019-20. Then Department of Health give that money to other organizations to commission the services and to provide the services. So basically, it gives almost 4 billion pound to Public Health England. It has given 4.5 billion, it kept 4.5 billion for some of its own organizations and its own management. And then it can give about 4 billion to Health Education England, because that is a big organization which actually trained the education workforce, the medical workforce in England. Then it gives the big chunk of money, almost 121 billion pound to NHS England. And the NHS England then subsequently gave almost 80 billion pound to clinical commissioning groups so that they can use that money to plan the services accordingly. So then they can give that money to a number of other organizations. Just moving swiftly, because I think I'm just against the time. So what happened when the money in 2019, NHS said, we cannot keep working on year-on-year basis. The money, that's the way the money is being distributed. So they came up with 10 years NHS long-term plan till 2029. And then they agreed with the government that you can make a commitment and settlement with us for 5-year funding. So these are the 5-year funding has already been agreed till 2023. And then they made some structural reforms. And then they have come up with the formula how the money is going to be distributed, which is based on age, based on needs, based on unmet need, based on deprivation level. So that's the way they come up with the formula. That formula has been used to distribute the money. And on average in England, there are 1,318 pounds per person is being allocated in England. That is average. but the maximum has been given 1,742 to a CCG in Knowsley, which is near Liverpool, and the minimum, which is almost 1,091, which is given in Oxfordshire. And you can see Oxfordshire is a rich county, and it is less people with less needs, so health needs, and this is the reason they have got less money per person per year as compared to Knowsley. But at the same time, when the money is given, the health system is being asked that you are going to be performance managed. For example, they're going to be performance managed on waiting times. They're going to be performance managed on the waiting list. So has the operation being done within 18 weeks? If not, then you've been asked that you've been given the money, why you're not doing the things at the right time. And then again, this is the whole thing about value-based healthcare, that you need to improve quality and you need, with the what resources you have got in hand. And the resources are being used. I have given you example based on cost, but resources are also being wasted, and there is also a lot of variation. And when there is a variation, it means that certain services are being delivered at higher cost in one part of the country as compared to the other part of the country, and that means variation. And then the last part of my talk is efficiency and value. Very briefly, the whole purpose of investing money and in a health system is to improve efficiency and value. And this is the work which is being done by Commonwealth Fund, which is a big organization in New York. They look at the health system of OECD countries, and then they say that his independent review, and then they say which of the health systems they have got the best quality and efficiency. And you can see the United Kingdom is almost #1 in all the parameters, including quality and efficiency. And they are spending almost, this is a little bit old data, but in 2020, we are spending almost $4,500 per person per year. That's the total we are investing. And our outcomes are better than the countries who are investing more than that. And the reason for that, very quickly, we are very keen in the NHS that we need to have very reflective approach. We have done a national reviews. For example, there is a Carter review. We look at there need to be a national procurement. So all the drugs, everything are being bought nationally. So it is not like every hospital is buying its own drug. So the NHS England has got a central procurement function. So it means that you can have a better negotiating power, and then you can do the lot of other things, the shared back office support. Then we had another review called Watcher Review. Here's a famous person, Watcher from USA. He helped us in 2017 how the digital technology can improve the NHS efficiency and effectiveness. And then we had another review in 2017 called Naylor Review. It looked at how the NHS buildings are being used effectively, and we can save £500 billion. And then NHS QUIP program, it is called Quality, Innovation, Productivity and Prevention Program. When there is a 2008 economical challenge happened all across the globe, we had 20 billion efficiency gap, and we worked through this program to deal with the 20 billion efficiency. Then we have got Care Quality Commission, which not only regulate the outcome, it also regulate the finances of the hospital. So it asks the hospitals that I'm looking at your quality indicators, I'm looking at your financial indicators. And then, by the way, all the hospitals in England, they have got the PLIC system. It means patient level information and costing. So they know how much is being used, how much each patient is costed. So all the drugs given to the patients, they have got patient level costing. It means they can look at the efficiency more effectively. So
Adil, I think we need to wrap up so that we can take some questions.
Exactly, I'm going to wrap it up. So this is the ideas for Pakistan for its journey. So the whole purpose, that is the reason we are joining forces with our alma mater, King Edward Medical University, saying, what are the ideas we can give to the Pakistan on this journey? Pakistan has got a very ambitious vision, but in the light of very scarce resources. I said health is wealth, and what learning they can take from UK. So if you look at the state of Pakistan health, at the moment they are using almost $37 per person per year. And it is only almost 2% of their 1.5% of their GDP, and their GDP is much less as compared to many other countries. And if you look at the health challenges they are facing in 2019, it is a mix of chronic diseases and it's a mix of communicable diseases. So they have got much bigger challenges. They are investing less. It means that they need to think about value-based approach. And these are just 3 ideas before I conclude. First of all, whatever I presented, you might have seen it is underpinned by a lot of data. So our data system, our intelligence system is very, very strong. And it means that applied health intelligence system need to be support financial planning and decisions at national, provincial, and district level. Second is quality and outcome-based reimbursement. Over here in the UK, in England, we are doing the quality and outcome-based reimbursement to hospitals. And over there, they need to start thinking on those lines. And then I think knowledge is power. National Institute of Service Innovation and Improvement, they need to start thinking something on those lines, having a national think tank, which can help them to move in the right direction. So just to conclude that we are here to support Pakistan and we can work together. And that is my last message, and God willing, we can work together and we can think that how Pakistan can be a good example on the healthcare finance front. Thank you.
Thank you, Professor Adil. Really educational and very informative talk. I think in the interest of time, we have probably time for only one question, which I'll pick up from Professor Asghar Naqi. For a low-income country like Pakistan, how can we improve health financing, ensuring less emphasis on out-of-pocket?
Well, I think Professor Naqi has asked a very important but very fundamental question. I think it's difficult. In summary, as I mentioned before, Pakistan has got a similar approach like UK. It is a devolved approach. It means that we have got opportunity to have a little bit test and try approach in the 4 provinces. But the key thing is that they already started health cards. I think that is a good step in the right direction. It is a good so-called insurance, but my biggest concern is that still in Pakistan, we are talking about quantity, about access of services rather than quality. We are still working on the secondary care system rather than the primary care and prevention. So 60–65% of our people in Pakistan, they live in the countryside, in the villages. So how come our health system is concentrated in big cities? And then why it is having a more secondary care approach? And I think these are the things we need to be thinking, the prevention. Cancer, again, a very good example. I was in Shaukat Khan thinking about the cancer registry, that how we know how much cancer is in Pakistan. Same apply to diabetes. So if we are trying to improve out-of-pocket expenses, we need to be thinking where the money is going. At this point in time, we do not know where the money is being spent and how much is out of pocket. And last but not least, the registration with the GPs. We have got an excellent family physician, but private system in Pakistan. We need to work, secondary care need to work with the primary care so that most of the bulk of the patient's burden of disease should be taken care of in the primary care rather than the secondary care. I remember my days in Mayo Hospital, it hasn't changed much. In A&E, most of the people are coming in A&E, they were coming over there because they can't be seen anywhere else. So I think these are some of the basic things, but I'm always available. People know to help and to work with anyone in Pakistan who would like to know more. Thank you.
Thank you, Professor Adil. Thank you, and thanks for keeping to time as well. So I think there are 1 or 2 more questions, and there might be a few more questions coming, but we will have an opportunity to then pick up those questions through the website. Okay. Thank you for your time.
So I think at this point I need to take back my chairmanship, and I would request Mahmood Shafiq Gill to come on board and kindly do his presentation. I know Shafiq for a number of years. I don't want to add more. He's an excellent pathologist. He's very a good leader in his own specialty, and he's member of the...
Sorry, I'm interrupting you. Sorry, the next turn is for Jishnu Das.
My apologies.
And then, my apologies. Sorry, I think I should have given you the sequence before. So apologies. Okay. So our next speaker is Jishnu Das, who is a lead economist in the Development Research Group at World Bank. And his areas of interest are education and health. He is well published and he has done a lot of work in India and Pakistan in supporting education and healthcare. And his talk is around health insurance systems and can we explore those opportunities in Pakistan. So thank you, Jishnu, for agreeing to give us a talk. So it's over to you.
Thank you, Shafiq. I'm just going to share my screen. One quick detail, I did manage to leave the World Bank and I'm a professor at Georgetown now. So I wanted to talk briefly about, kind of the work that we have been doing in India and other countries over the last 2 decades, and think with you about several issues that have come up. And I must confess that I haven't worked on health in Pakistan, although I've had a long-standing work program on education. So, things that are not, germane to Pakistan, we'll have to think about. Okay, so I want to start with what the problem that we are trying to solve really is, right? I mean, what is it that we are trying to do? And I want to put down a picture of what people think the underlying landscape is for healthcare in countries like India and Pakistan, and in fact, many other poor countries as well. And that landscape has kind of 3 broad features, the way people think about it. One is that many people, especially the poor and especially those in rural areas, have no recourse to healthcare. The second is the public sector can provide quality care, but doctors are overworked without the support they need to do their work. This needs to be kind of changed a little bit because there's an increasing recognition in the government that healthcare workers in the public sector are not performing at the standards that they're supposed to. And third, there is a big sense that patients, especially who are those who are poor and illiterate, do not know what kind of healthcare is good for them. So the idea has been that if you could get them access to certain types of healthcare more promptly, health outcomes will improve. So the way that things are going in India, the policymakers and the people who are thinking about this are really divided into 2 camps that have become exceedingly ideological. So one camp is what I call, think about as the public sector camp. And the public sector camp says, look, the current situation is due to a lack of state commitment and funding for the public sector. Because the private sector, to the extent it exists in rural areas, is predatory and it takes advantage of patients' ignorance. And therefore, all we need to do is substantially increase funding in the public sector, and we'll be able to build a glorious NHS-like health system. This is not just talk. India has had almost 10 reports since 1950 urging for an NHS-like investment in the public sector, and that will solve all problems. Of course, to date, we are still where we were roughly 40 years ago. The second ideological camp, and this is a new camp that has become more and more kind of powerful after 2000, is the private sector camp. And there the thinking is, dekho, we have tried and tried to improve the public sector, but humse nahi ho raha, it's too hard, right? And the essential idea seems to be that we have no control over the behavior of health workers. The doctors are often absent, but, the care is not that good. So now it's time to try something else. And if we just hand over more care to the private sector, perhaps using public funds, this will lower the burden of the government. And that idea is combined with the idea that a monitoring and information system honi chahiye, a very strong monitoring information system and punitive monitoring. So this is the idea that har hafte the chief minister will call meetings and then he or she will say that, this secretary is not performing, or that secretary is not performing, or this hospital is not doing well, and that will improve the overall functioning. So what I want to do here is I'll show you that the prevailing views of the healthcare system are not based on rigorous empirical work. I mean, if you look at what's actually happening, it's quite different from what people think. And this work will show you that access is quite high, but quality is poor. So we have to think not about universal health coverage. In some sense, most of our countries have had universal health coverage because you can always go to the public sector and get free care, if it's as one option. But towards effective UHC, which means you get the quality that you need when you go to the health system to access care. The second thing I'll show you is that handing over provision to the private sector is a very difficult task that requires regulatory and monitoring capacity that we don't have at the moment. And then I'll show you that even if we had it and built it up, it may be very hard to implement even in the best of circumstances. I'm going to argue that perhaps improving the public sector is probably our best option on the table, but it requires equal commitment from the government and from healthcare workers. And this is two parts. One is the way we have devised our systems. It's often putting healthcare workers in a situation where it's impossible to maintain motivation. And I'll give you a specific example. And as a result, what happens in our system is we have produced a politics of blame, right? The moment things don't improve, things don't go our way, the first thing we try and find is ye kiski galti hai, right? Rather than saying that it's a tough situation and what are the pragmatic solutions that we need to put on the table to move things forward. And I kind of, working in India now for 20 years on this, I think the biggest problem we face is thinking we can solve this quickly, right? So for the last 20 years, we have always needed a solution that we can implement and solve the problem in the next 4 years. But 20 years later, we are still grappling with exactly the same problems that we had 20 years ago. So clearly, if we had actually said we have a 20-year horizon, I actually think we could have got much further than we have today. And increasingly, I think that the biggest priority is not what financing system we have, not what exact policy we follow, but how do you rebuild the trust? And I'll tell you, we can talk about trust in the questions, but how do we rebuild the trust between doctors and the patients? How do we rebuild the trust between people who are employed in the health system and our secretaries and our ministers? How do we rebuild the trust in insurance and a patient, right? And that is going to be the foundation for any solution that we think about. So let me show you this. So this is access. So I should point out that these are data that we have tried to collect over the last 20 years, and it's been backbreaking work because these data just don't exist. And in Pakistan, they're not available at all. So these are just, we went to 1,800 villages spread throughout India, and we went into these villages and just started counting ki yahan par kitne log hain who provide healthcare. Right? And this is not a neighbor or a person doing something small. This is somebody who actually has a clinic, who's charging for healthcare in some form or the other. And you'll see that the numbers are completely unimaginable relative to a landscape where people think ki koi hamare paas healthcare providers hai hi nahi. The average in India, this is the average, right, that we are talking about. In India, at this point, sorry, I'm just trying to get my screen thing to work. Give me 1 second. Yeah, sorry. The average in India is 5.93 healthcare providers per village, right? Hamare gaon mein there are about 6 healthcare providers. Ye kaun hai ye healthcare providers? Well, 80% of them don't actually have formal medical qualifications. So one thing that I keep pointing out to the government is that 80% of our primary care is provided by doctors or informal providers who do not legally exist, right? But here's the interesting thing, it's not as if these healthcare providers, there's a very strong correlation which we think between how many providers there are and what your health outcomes look like. Some of our best performing states, for example, Kerala here, there are 3.64 healthcare providers per village. If you look at a state like Chhattisgarh, which actually has pretty poor health outcomes, it has 11 healthcare providers per village, right? You think about those numbers, there isn't a single, I'm sure Dr. Ali can tell us more, but I doubt that there's a single village in England that has 6 healthcare providers or 6 doctors sitting and practicing in it, right? So we have an enormous amount of access. The problem really is quality, right? One thing I should point out is this is not just India. I mean, we have gone and now started counting patients and doctors in multiple countries around the world. And I'll show you, this is for Kenya, which has about 10,000 healthcare facilities. This is the really interesting point, right? I mean, most of our policies seem to be built for this group. We think that there's a village, gaon mein, there's one healthcare provider, or wahan par hame kya karna chahiye, right? The reality is only 6% of health facilities are what we call standalone, which is there's a village, ek yahan par healthcare provider hai, and that's what we are trying to improve. The reality is 52% of healthcare providers are in situations where there are 8 or more health facilities right next to each other. And in fact, 48% of patients are going to markets like this, right? Only 8% of patients are going to markets like this, right? So a general phenomenon is access, even in rural areas, is far higher than we have thought it previously to be. Second point I want to make is there's a big problem with quality. So let me show you a couple of slides on this. So this is labor outcomes observed while a mother is giving birth, and these are 2 district hospitals that these authors stayed in. So yahan par they've separated into on admission, from pushing till delivery, and soon after birth. Agar aap dekhein, you look at things like partograph use or appropriate hand hygiene, it's almost 0. You look at whether the cord is cut with a sterile blade, whether there's appropriate hand hygiene from pushing till delivery, or appropriate maternal infection management, it's 10% or lower. And if you look after birth, whether there's maternal blood assessment, whether there's appropriate maternal infection management, whether there's postpartum counseling, appropriate newborn infection management, all these numbers are under 30%. In fact, something like appropriate newborn infection management is almost never done, right? Much of my life has been spent understanding quality in primary care. And one of the techniques that we have invented, kind of worked with quite hard and trying to, increase its use in big populations is the use of a standardized patient, which is a patient we train, not a really sick patient, but a person we train to present certain symptoms to a doctor and see what they do. So this is the case of a patient who goes to a doctor and says, Doctor Saab, मुझे सुबह बहुत फिक्र हो रही थी, मुझे ऐसा लग रहा था कि मेरे छाती पे कोई बैठा हुआ है, कोई भारी सी weight मेरे छाती पे है. I have, crushing pain, right? And the person has, if the doctor were to do his or her job properly, it wouldn't be hard. We are not trying to confuse the doctor. We are not introducing any comorbidities. The doctor should understand that this is angina. Hard to tell whether it's stable or unstable, but they should refer the patient on to a hospital, perhaps ask for an ECG. And as we all know, aspirin in that time is fairly beneficial. So they should perhaps give an aspirin. In patients ke saath actually kya hota hai, right? I mean, doctors spend about 4 minutes with such a patient. We don't have nurses or anything before that. They ask about 3 questions. They do about 1.5 exams. They charge, and they give 2 medicines. They charge about 31 rupees. But agar aap inme dekhein, so about 24% of doctors actually recommend an ECG. You know, basic vital signs, pulse, auscultation, blood pressure, temperature. Agar ye 4 mila ke dekhein aap, it's less than 10-20%, right? And even if you look at, you know, asking questions, history, all of these issues, family history, 1%, family history to koi puchta hi nahi hai hamare interactions mein. Even whether you smoke, very, very minimal. What were you doing when this happened? Very minimal. Even things like pain radiation, which this patient would have said, the pain radiated to my arm, it's less than 1 in 6 cases, right? So when you start putting all these numbers together, you get something like this, right? Which is, you know, and this is now, we're showing this across multiple, so these are all India, but this is China, this is Kenya. We are starting to show this in multiple primary care scenarios. Patients are getting somewhere. Kenya is really, I mean, I was surprised at how good Kenya is, but on average, our patients are getting the incorrect treatment somewhere between 50% to 90% of the times. Right? And for those of you who've been following all these issues about antibiotic resistance, they're getting unnecessary antibiotics somewhere between 33 and 68% of the time, right? What does that mean? When you put that together in terms of what the money that's being spent that's medically avoidable, which is up doctor ke paas ja rahe hain, but the doctor is treating you for the wrong thing. So we think about that as medically avoidable costs. It's through the roof. Madhya Pradesh in India, 64% of all expenditures medically avoidable. West Bengal, 81%. Delhi, 70%. Mumbai, 34%. China makes 93%. Kenya, 80%, right? So most of the money that's being spent in our medical systems is going towards money that patients are paying, for which they are getting the wrong treatment all the time. So one of the issues that's been raised is, well, maybe that's because this is, you know, not very good doctors in the, or providers in the private sector. That's not the reason. We did this very interesting study where we did exactly the same thing with public sector doctors. And we looked at the public sector doctors in their public clinic. And then we sent exactly the same patient to the public sector doctor in their private clinic, right? And what did we find? Well, first of all, in the public sector doctors, they're pretty much performing the worst in this entire system. They're worse than the private sector guys. Remember that 80% of these people don't have formal medical qualifications, right? But when you take exactly the same doctor and put them in the private sector, this is exactly the same doctor. So they're in the PHC, in their public sector, they have a private clinic here, sham ko yahan par jate hain, or even during the day, and we are sending exactly the same patient here, and then some months later here, right? They suddenly jump from being the worst doctor in the system to being the best doctor in the system. Right? I mean, look at that gap in their performance for the same person between the public and private care, right? So because of these kinds of data and information that's arrived over a substantial period, in 2007, the Indian government set up a big health insurance scheme. I was part of the group that set it up. It now, you know, by the time it was it was expanded. By the time I left, it was about 150 million people. Now the Indian government has expanded it, called it a different name. It's called either the PMJ or Ayushman Bharat. Ayushman means healthy, depending upon, you know, specific parts, but the basic scheme remains the same. So in the scheme, what happens, the way we set it up was that the state government starts off by issuing a tender at the level of the district. And then insurers put in bids. What is the bid? The bid says ki, for every household that enrolls in the scheme, the premium that the government will give me will be, say, rupees 500. Ye unki bid hai. Right? Based on that, the state government then selects an insurer. It gets approval. And then what it does is it gives a list of all poor people in the state. So there's A, there's B, there's C, there's D, there's E. And the licensed insurer signs up with the smart card provider, who then goes and tries to enroll these people, right? So then the government gets back data saying, inki enrollment ho gayi hai, inki enrollment nahi hui, inki enrollment ho gayi hai, inki enrollment ho gayi hai. The government looks at all of these. Well, that's 3 households enrolled. So the licensed insurer gets 1,500 rupees, right? Uske baad kya hota hai, right? After that, the person who's insured can go to the hospital. They take their insurance card with them, and the hospital is supposed to give care in a cashless fashion. And when the hospital gives care, they get money from the insurer. So there's a hospital here. There's a hospital here. The patient goes to the hospital, gives their card. Say they get an appendectomy. The licensed insurer then pays the hospital whatever the rate is for the appendectomy, which has been decided by the state government. Right? Ab isme problem kya ho gayi, right? I mean, so what we found, and there was a very nice paper that did an evaluation of this program, it actually showed that not only did the program not have any impact on health outcomes, it actually failed to decrease the financial burden on households as well. Right? So what failed? And the 2 things, right? The idea was that by handing over provision to the private sector, government responsibilities will be lower, right? And I was there for the first 2 years of the scheme, and I thought that over time it will build up. The reality is that administering a scheme like this requires enormous government capacity, right? Hamare desh mein, there are 17 insurance ombudsman offices. All of them are currently vacant with a backlog of 9,000 complaints, right? If you look at the US, which has a similar scheme called the Medicare, it employs 6,000 people to cover 44 million beneficiaries. I'm going to take some states, maybe you know these states, maybe you don't, but in a state like Uttar Pradesh, which is our biggest state, this would imply they would need 12,000 people to administer the scheme, right? With 100 million enrolled. If you think about Punjab, which has now a population of about 80 million, you would need to hire about 10,000 people to administer the scheme properly. Hamari actual staffing kya thi? UP had 42 staff, Bihar had 10. Even in southern states that tend to do better, it was lower than 100, right? So suppose that Punjab, if Punjab thinks of a scheme like this, ki hum health insurance denge, and then the private providers will provide that, and then they say, theek hai, 10,000 staff lagenge, we will train them for 2 to 4 years and then put them out and maybe they'll run the scheme. Will that be sufficient? Well, actually, it turns out it's not, because the biggest single problem that we hit on this scheme is really pricing. I want to spend 5 minutes kind of understanding pricing and then stop there. So the way the health insurance scheme runs is with something called DRGs. So these are called diagnostic rate groups for 700 procedures. So what are these? These say, if you have a birth which is normal, तो आपको जो भी 10,000 रुपए मिलेंगे. If you have a birth that's an episiotomy, then you will get 12,000. If you have a C-section, then you will get 22,000, right? These are the rates that need to be set by the state government. Now, here's the problem that happens. So for each procedure, hospitals are reimbursed a fixed rate. Right? So, you know, in the Ayushman Bharat, this is an actual price. A stent will be reimbursed at a stent will be reimbursed at 40,000, but a heart bypass at 1.2 lakhs. Right? As a result, we face two critical problems. Pehle hamare paas jo masla hua is that any uniform price means that some hospitals will make a lot of money, right? So we had hospitals that were charging 2,000 for a C-section, and we had hospitals that were charging 25,000 for a C-section, right? So the big problem we ran into is what price should we set? Agar hum 5,000 kare, to inki to mauj ban gayi, right? I mean, these guys are all going to come into the scheme and they're going to make a lot of money, right? So that either leads to cost inflation. If these guys come into the scheme, well, that's not worth it for them. So either they don't enter the scheme, or what happens is they enter and then they refuse to accept the health insurance, or they ask for more money, right? The second problem we faced was, look, at the end of the day, it's impossible. It turned out to be impossible to monitor what patients actually needed, right? So in one state, for example, hysterectomies were overpriced. What happened? Every woman who went in, regardless of what she had, the hospital gave a hysterectomy, right? That's the first problem, that you end up getting care you didn't need. The second problem is something called upcoding, which is you know, the hospitals would do something, but then they would charge for something else. And I want to give you some data on this. So these are really difficult problems to detect at the best of times. So 15% of Medicare money in the US goes into fraud. Even with this big group of people who are trying to handle all of this, we don't have even the regulatory and judicial system in place. Hamare paas koi, so the insurance fraud comes under 420, which is your standard fraud, but there's no special regulation or law for prosecution of insurance fraud. It just doesn't exist. So hamare laws are not in place, the regulation is not in place, the judicial system is not in place. So every time we went to court saying, is hospital mein ye hua hai, the hospital would say, we are a necessary service. The High Court would give a stay order and say, nahi, aap kuch nahi kar sakte, right? So this becomes impossible to prosecute even when detected. So the problem is now, you don't just have a health system, you have a health system that's interacting with your regulatory system, which is interacting with your courts, and you have to change all of this, right? Let me give you 3 slides to end, and I know it's getting late. So this is work that Radhika Jain and Pascaline Dupas have been doing. They look at administrative insurance claims data from the state of Rajasthan in India. And let me just show you a couple of things, right? So pehle to what I was talking about, ye dekhen, ye rates jo set hain, aapne 2,000 rupaye ya 4,000 rupaye ya 5,000 rupaye C-section ke liye laga rakha hai, but a hospital that was earlier charging 10,000, wo kya karenge? Right? So they start charging patients out of pocket. So these guys have done interviews with patients. These are a bunch of different procedures. The mean out of pocket, 46% of patients are paying extra money. About $30 on average, which you saw from Dr. Ali's presentation, is an enormous amount of money for these households. And many of these households are living on less than $1 a day. Second part, well, what do people do when package rates change? So this is Rajasthan, and you'll see on 13th December, they changed the package rates, right? So basic delivery key price went up from 3,500 to 5,000, right? On the other hand, forceps delivery remained the same. Preeclampsia management went up a little bit. This is antenatal care visits. They started paying more, right? What do we see? The day that the price change was announced, your episiotomy dropped because the price didn't change. Your basic deliveries went up. These are not small numbers. This went up from 10% to 25% just because of a small change in the prices. Even more startling are things like ear procedures. I don't know what these exactly are, but a TIM plus a mastoidectomy went up from 50% to 85% of all these issues, and the tympanoplasty dropped from 40% to almost 0 just because of a change in the prices, right? So this is a genetic problem with health insurance, right? And people don't understand this, but the US is a complete disaster. So in the US, you have no idea what price you're going to pay before you go to the doctor. And the point is, the insurance won't even tell you whether the price, what is the maximum they are willing to cover. So I'll give you one particular example. You can go to this.
It's time to wrap up so that we can allow some time for questions, please.
Yeah, I've got 1 minute. Let me just spend 1 minute more, if I can. So this is a really nice article that looked at people who were given an IV after food poisoning. And what you notice is they all got the same thing, an IV bag that cost 86 cents. But somebody went to one hospital, jahan par they charged $393. Somebody else went to another hospital where they were charged $787, $546, $91. This is how crazy the pricing is in the US, right? So let me kind of end up from here, and maybe we can take some things in the questions. My summary is there's going to be no quick fix to this problem of how to provide healthcare, right? And I increasingly think that the biggest problem we face is what I think about as magical thinking, that either handing things over to the private sector or just more funding to the public sector will solve our problems. We have to recognize that healthcare is about people, and we're still learning how to manage and motivate our workforce. And if we start with some humbleness and say, this is an enormous amount of work, but we can solve this, but only if you're willing to discuss our problems openly in a spirit of improvement rather than an atmosphere of blame. Let me stop there. You've been time, and we can, let me stop my share there and we can take it forward.
Thank you, Jishnu. This was excellent. And I can see that you've got a lot of good example and data with your experience in India. And of course, you reflected what's happening in USA because it's the insurance-based system. So I think we have got some questions. We've got some time for questions. Let me start by saying that you started with two schools of thoughts. One is the public sector, other is the private sector. And of course, the data and argument went, and you were mentioning about 80% of the workforce where you did the data from your villages, they are not recognized. And the people are asking that, are they part of the formal or informal system? And of course, if they're part of the informal system, then how they are playing a part, which is maybe not high quality input.
So I think that they're totally part of the informal system, but there's nothing really called informal or formal. So most of them actually get a huge amount of training by working with, they all start out as compounders in, doctors' clinics. So they get an enormous amount of training through that. Then they start to go in and build their own clinics. The question of are they low quality or not? Well, it's complicated, right? Because we treat qualifications as quality, but qualifications is not quality. Quality is what a patient gets when they go to a doctor. And what we have shown repeatedly is there's massive variation in quality, whether you look at fully trained doctors or you look at informal providers. So there's some informal providers who are providing better care than fully trained doctors. In fact, I can show you a graph which shows the average informal provider in the state of Tamil Nadu is better than the average fully trained doctor in the state of Bihar. Because Bihar mein medical training institutions ki halat bahut kharab hai, but in Tamil Nadu, they're actually doing really well because they're training with fully trained doctors for 10 years before they're opening the clinic, right? So it's really hard to come up with an idea of what is formal, what is informal. In the legal regulatory setting, these guys are actually illegal, right? So 80% of India's primary care is provided by people who are illegal. This is why we are not able to move forward, because we can't have an open discussion about inke saath kya karna chahiye. We can't ban them. We've been trying for 50 years. लेकिन आप ban करेंगे तो किसी के पास कोई option ही नहीं है.
Thank you. I think Isha, that's good. But let's pick up two other countries, which are the neighboring countries, China and Pakistan. China has got a very good village healthcare workers, and Pakistan has got lady healthcare workers, which are maybe the biggest program in the world, almost 100,000 people. How best those structures could be? I mean, China has used very effectively by providing care to maybe the biggest population in the world. And the Pakistan is also doing its best by utilizing the lady healthcare worker program. What is your experience, although you said they are illegal, or what is your experience in order to raise the standard of their care they are providing? Because I think it might be hard to regularize them, because then the doctors might become, I think there's a very recent issue in India saying why you are asking those number of people to do operations. But so what's your experience based on your work in India?
I'm totally data driven. So we have done this in China as well. The China village doctors are 10 times worse than the informal providers I'm talking about. Unki to halat hi khasta hai on that. So the patients start getting decent care only once they're going to the county and the townships. And the basic process of accountability is if the doctor doesn't provide good care, you know, these guys come with their village guys and they beat up the doctor. It's a really bad situation. So last year they had about 9,000 doctor beatings in the country. It's a terrible situation, both on these fronts. The village doctors are abysmal. They are really, really bad. We have a paper on this in PLOS Medicine, looking at this in the context of tuberculosis, where we compare multiple countries. So I think the problem is a lot of people think a lot of things without the data to support it. And our game is, let's put the data on the table and let's see what's actually happening. Again, when it comes to what do we do with these informal providers, you know, my story is always, be pragmatic. Abhi kya kar sakte hain? How can we move forward? So I worked in the government of West Bengal to evaluate a pretty extensive training program that lasted about 50 weeks, 3 days a week. We showed that that training program improved the care that these guys were providing quite a lot. So the government actually scaled it up. As you can imagine, it had massive pushback from the Indian Medical Association and others, but the government's going ahead, right? So, and it has gone ahead for the last 2-3 years. So I think these are all issues where we just need to move away from ideology and say what's pragmatic.
Thank you, Jishnu. I think just to sake of time, my last question. You talk about a lot of unwarranted variation. We have the similar challenge in the UK. We talk about unwarranted variation in quality, and we define quality very, very clearly. And maybe this is one of the hallmarks of the NHS. When we say that, are you providing quality care? Doesn't matter you are a nurse, pharmacist, doctor, or anyone else who's providing healthcare. 3 things: safety, effectiveness, and patient satisfaction. And we have got the data on all those 3 things, like on hospital level, and even many of the surgeons like Cardiothoracic Society of the UK, they were the first one, they start putting the data on those parameters on the web. So you can find a doctor and then you can look at their quality outcomes. And of course, it needs to be assessed based on the case mix. So again, you said about variation and gaming. Has anything been done on the gaming front? Because admin cost is the biggest cost you mentioned. And the second thing you said that I think the same type of treatment, but the cost is different. So what's your experience? Because that's a similar thing, almost similar approach with the Pakistan card, that they are health card, that they are asking the private sector to provide care. It is a good thing to do that, but what about gaming and unwarranted variation?
It's absolutely impossible to control. We don't have the regulatory systems, we don't have the courts, we don't have any expertise built up to control this. In fact, in Rajasthan, the scheme collapsed. So we are seeing this in state after state. I think it's a disaster. And frankly, it's impossible to control it. There is no solution. I mean, the US, with billions being spent on Medicare, can't control it, right? I mean, remember that, you know, it's after the fact, right? I mean, just look at the opioid crisis in the US. That was entirely built up of insurance, right? So it's something that becomes really impossible to control once you move in that direction. I just don't think there's a solution. We have been working on it for the last 10, 12 years. You can come up with some ideas of making it less worse, but there is no proper solution to this issue.
Thank you, Jishnu. I think this is very helpful because I took the stance on behalf of NHS saying what Pakistan can learn from the NHS. You helpfully told us with your experience, of course, from the US, but also in particular in India on the insurance. So I think there are a lot of things which our audience can learn and they can ponder. And of course, by the end of this session, we should assume that there might be some good ideas for to be taken forward in Pakistan. Thanks very much for joining us. Please stay in tune because maybe there are other questions at the end. So now at this point, let me take over, which I was trying to take over before, that my colleague, Shafiq Gill, he is going to present about how the NHS or how the staff is being taken care of. And I think the title is very, very good. In health, in sickness, in death, how NHS looks after its workforce. Thank you, and over to you.
Thank you, Professor Adil. Good afternoon and assalamu alaikum. I think the previous two speakers have given a really very good overview in terms of the healthcare finances, and different financing models. Obviously, whenever we talk of healthcare, we primarily talk about patients, we talk about money, we talk about quality, we talk about systems. I think one key component in any healthcare system is the staff who deliver that care. So I'm going to have a bit of discussion on that topic. And the example I'm going to use is National Health Service from UK. As an organization, it is one of the 5 largest organizations in the world. As an employer, it employs about 1.6 million people. And that is split into like hospital-based staff, general practices in the community, and dentists. And if we look at the range of careers it offers, it's about 350 different types of roles it offers to its staff. When we look at the split of those staff types, obviously bulk of the staff is what we call support to clinical staff or nurses and midwives. Doctors make a relatively small component of the overall healthcare staff in the UK, and I think that's the reflection everywhere in the world. And as we talk about like how do we look after our healthcare staff, we look at a sort of a range of what we call staff benefits, obviously salary being the key pillar, but then there are so many other benefits in different forms and shapes which we need to talk about. So I'll be covering like what pay systems are there, how we manage staff leave, sickness, indemnity or protection in their work, and then what type of working environment they have, and are there any opportunities for career progression? Can they sort of develop other professional interests other than their main role? And how do we look after them when they stop working? So NHS broadly offers like 3 types of salary systems for 3 different staff groups. One group is medical staff, either when they're fully established consultants, general practitioners, or dentists. I have just for a notional purpose put here like a salary range for a consultant in the UK, which starts from around £82,000 a year to goes up to £107,000. Trainee doctors get about 24,000 to then can go up to £60,000. Then there is a small, relatively very small group of what we call very senior managers, people like chief executives and executive directors. Their salary is around 100K and goes above that. Bulk of the NHS staff is what we call agenda for change or non-medical staff. They are roughly split into pay bands 1 to 9, and the salary range is around 18,000 to can go up to £100,000. And there are principles or basic principles defining how the pay system is developed, and it's primarily A, people are treated fairly, B, they are appropriately rewarded for their work and contribution. And that is what we call basic pay. Any work done above their contracted hours, which is usually 37.5 hours for agenda for change staff and up to 40 hours per week for medical staff. Anything they do above and beyond that, that is separately paid, like either in terms of extra hours, shifts, overtime, or on-calls systems. And then if staff work during any of the what we call public holidays, then they get paid separately for that. So that's just to get a concept of how staff get rewarded, or how the pay structure basically works. For anything, and that's just primarily example for medical staff, anything they do above and beyond their normal duty, which we define broadly as excellence, basically well above their duty, then there is a national system of what we call clinical excellence awards, and people have to apply for this. And some of these are given by the local hospital, some have to be sort of competed nationally. And they have been more recently under review, but this is one of the, again, reward mechanisms where people who go well beyond their normal duty to make some innovation, to contribute to service development, make significant changes to the service, they get rewarded. There is an annual leave system, which again is minimum of 4 weeks, and actually 4.5 weeks plus 8 days, which is the national bank holidays. And then as people progress in their career in terms of the length of service, that gets increased to 33 days per year. And that is the annual leave. And these are working days. Then there are benefits like maternity and paternity leave. So if all pregnant people are entitled to 1 year leave, and not all of this may be paid because that depends on the length of service. But then they have what we call the basic job protection during their maternity leave. So they cannot be sacked from their job. And more recently, there has been an element of what we call paternity leave. So fathers are also entitled to up to 2 weeks of paternity leave. As far as the 1 year maternity leave is concerned, previously it used to be all availed by the pregnant female, but now as it's 1 year leave, and owing to shared childcare responsibilities, that can also be shared between both parents. That's one of the relatively new features. And there is a whole sort of range of other leaves, which like we say sort of additional commitment leaves, like carers leave, people who have caring responsibilities. To maintain continuity of care, they can avail some carers leave. They can get some time off for their dependents. If there are any personal and family reasons, especially any emergencies, things like that, they can get some time off for that. And then if people are called in for any civic or public duties, like jury duty is one of the common phenomena in the UK, then they get time off for that. And again, for any sort of extreme situations like bereavement, any sort of domestic crises, then there is some leave entitlement for that. So there is a good robust leave package for staff members, and that applies to all staff members in NHS. If people become sick, again, depending upon their length of service, there is a range of what we call sickness absence, which is up to a point it is fully paid. And then they can go like what we call half pay before they then go on to unpaid leave, and that can be sort of, but their service continues. If someone is on annual leave and they become sick, that annual leave then converts into sick leave, and then when they recover from that, they can still then avail their remaining annual leave. So that's again one of the perks, and that it does not affect people being on annual leave. When people have been on sickness and they return from their sickness, sometimes they may not be able to fully resume their full scope of the job. And then in discussion with their manager, they can have what we call a phased return. So they can start slowly and then build up their sort of energy as they are able to then come back full time or to wherever they left their job. at the start of sickness. Similarly, if someone experiences what we call terminal ill health, they can be given their full pension regardless of their length of service, and I'll cover that a little bit as we talk of pension. And there are similar benefits for if someone dies in service, there is a reasonable amount given to the individual which can then cover their provides for their family after they die. In terms of maintaining their professional development, again, all staff have access to some sort of study leave. Here I'm using example primarily for medical staff. They get 10 working days leave per year as study leave, and there is some study leave funding available which varies slightly from one hospital or one organization to the other organization, but these days it's roughly in the range of 600 to 1,000 pounds per year. In addition, medical staff, especially when we say consultant medical staff, they get some protected time in their weekly job plan, which we call for supporting professional activities, or basically time for their professional development. That again varies, but it's roughly 10 to 15% of their week's time is protected for their own professional development. In addition to that, for people who are supporting the NHS in some sort of wider capacity, either within their organization or at regional or national level, they can use up to 8 days professional leave per year, like to support any Royal College work, to support any union activities like British Medical Association or similar organization, to support any regional quality or service improvement activities. Many organizations offer what we call in-house training, both for like the clinical role development, for broader professional role development, or for other service-related activities. And for people who want to sort of further develop their educational profile, many organizations provide some sort of funding and time of support to do like master's, PhD, or any dedicated fellowship or any other training or further education. I think that's more about the perks, but then one of the key elements someone who is employed is people are looking for what type of working environment they are working into, because people spend a lot of their lifetime in their workplace, and it's really important that there is the right work environment. And NHS looks into what we call safety at work. Every department, every team has a safety system or a safety culture where they want to make sure the working environment is safe. Every organization has a statutory duty to provide mandatory training to their staff so that they can do their job well. They can keep themselves safe, like fire training, like information governance to make sure the patient data and overall data systems are secure, and occupational health type training, looking after each other's moving and handling, things like that. Indemnity is one of the features which NHS provides. So in doing their job, it's always possible to make mistakes because healthcare is a very complex business, and it's very easy to make mistakes. So as a national organization, NHS provides indemnity. So if things go wrong, it would support its staff, and it will pick up any sort of legal defenses if needed, up to the point where there isn't criminal negligence. And obviously if there is criminal negligence, then they have to make a decision that how far they want to go to support or protect staff. And then I'll briefly touch about disability and diversity and equality. And one of the key features as people have more family responsibilities, just like as Dr. Adil reflected, UK is going through what we call aging population, so that is also reflected in staff as well. So there is a range of what we call flexible working arrangements, and even I sometimes struggle to understand all of these terms, so I've just like highlighted some. So broadly, people can work less than full time. They can, like 2 or more than 2 people can share a full-time job. They can like share, and they can get paid proportionally for that. They can choose variable flexible hours where they can work few weeks and not work other weeks, or they can have what we call annualized contracts where they can overall deliver annualized hours but in like a condensed fashion. and they can also pick up weekly rota in a more of a flexible way, like maybe linked with their compressed hours. They can do 5 days work in 4 days, but spending extended hours, or they can have their duty timings linked with that, let's say, school timing, so that they can look after their children. They can similarly, when they come to the age of retirement, they can what we call retire flexibly. They can reduce their hours, they can take a break and come back, and then they can work different arrangements. So there is quite a big range of flexible working arrangement just to support staff. Similarly, there are many other rewards, like many organizations would provide what we call childcare facilities on site. There are salary sacrifice schemes, which primarily mean that you can sacrifice a bit of your salary, and you can get support from the organization to buy equipment like computers for your home or work. You can buy a car, you can use money for many other purposes in working in partnership with your employer. You can buy future annual leave, which is a new scheme which is being rolled out in many organizations, where you can buy up to 5 or few days of annual leave for future years, and then you can use it as a lump sum at one time. Although many organizations are what we call devolved organizations, they create their own local employment contracts and systems, but broadly they employ staff on national terms and conditions, and that offers a sense of job security within NHS, because although you're working for a local organization, but you are on national terms and conditions, which gives you a bit of protection. Your staff record is on an electronic database, and that's what most of the organizations have now moved to. And that also includes your health record. So basically what that means is this is portable, just like your other benefits. So if you're moving from one organization to the other, you basically carry your benefits like length of service, your salary scale, and many other benefits are simply transferable from one organization to the other. Equality and diversity is one of the key sort of components within NHS, and there has been a lot of work recently, because it has been given a very high profile in making sure that there is equality within the organization, especially when it comes to gender, ethnicity, disability, sexual orientation, religious beliefs, or for any reasons where there are people with what we call protected characteristics who could feel that they could be potentially treated differently or disadvantaged in some form and shape. So there are now sort of encouragement mechanisms in place to sort of protect those individuals. Just if we talk of gender equality, actually out of that 1.6 million staff, and I mentioned about more than 1 million are women in NHS, so they make a large proportion of workforce, and there is a lot of work taking place in terms of supporting them, like through flexible working arrangements, through maternity support during maternity and childcare. And also there was an observation a couple of years ago that not many women are in senior management roles. So there is an aspiration to sort of support women, to encourage them to pick up more of leadership and both like clinical and general leadership roles, where they can be part of the hospital boards in future years. Similarly, NHS takes pride in supporting people with disability as an equal opportunities employer. So it has a duty to make reasonable adjustments to support people with any form of disability so that they can do their job, and they can do their job as normal as possible. And that's again, there is a statutory requirement to then report what we call data to national bodies to make sure all organizations are compliant with those disability rules. One of the other staff features is what we call minority ethnic staff groups. So Black and minority ethnic groups make about 1/5 of the NHS workforce. There have been recent initiatives to include, to sort of encourage them to pick up more of what we call senior level roles and have more say in the decision-making process and feel part of the wider NHS. And that is about like doing the day-to-day job. And then in terms of looking into opportunities, do people feel part of the system in terms of their career progression, and does organizations support them in that? Everyone gets what we call an annual review, whether it's in the form of appraisal or a personal development review, which helps them have a bit of reflection in how well their previous year has been, what are their aspirations for future, and how organization can support them in achieving those future aspirations. And that also, especially for our management colleagues, that annual development review links with their pay progression, which is more or less guaranteed, other than that you have to demonstrate that you have met your performance objectives. But it's guaranteed in the sense that if your manager feels that you're not meeting your performance objectives, they have to inform you well in time and work with you to develop a sort of a development program, rather than being a surprise at the end of the year that your pay progression is not happening. NHS provides access to a lot of training courses, and usually many NHS hospitals are linked with universities, and through those universities, then staff can access educational courses or further training opportunities. Similarly, many organizations provide what we call on-job training opportunities for their staff to help them move to the next steps in the ladder. And also, because it is one big NHS nationally and organizations work with each other, there are always opportunities for secondments for people to explore their future roles, either within their own organization or sometimes in neighboring or other organizations within NHS. And finally, when people stop working, NHS has a good pension scheme. When I say good pension scheme, there have been some recent changes from what I would describe it from very good to good, but it's still competitive. It's still good value for the money people put into that. And it's relatively competitive when we compare it with other NHS schemes other pension schemes within the country or with the private sector. And that pension scheme also includes any sickness benefits, as I mentioned earlier, or death in service benefits. So it broadly works on the same principle that employees make a contribution based on their level of earning. So it starts with 5% of the salary, goes up to 14.5%, and the employer makes another 14% contribution, and that's how the pension is built up over the years. So it's like a joint thing where cost is shared by the employers and the employees, and then it gives a sort of benefits at the end of the retirement. If people have ill health, they can take their retirement early, and it again depends on their length of service, but then generally it's like a supportive system. And if people become terminally ill, then they can basically draw their whole pension at whatever time they become terminally ill. Flexible retirement, we have briefly discussed. So people can step down, people can start either taking some pension and then come back working part-time, or they can completely retire. So there is a whole range of options. It is quite a complicated system, I must say, in the UK, but it offers a range of benefits where from within staff can choose. And another feature of the NHS is do staff feel they are listened to, and do employers sort of pay heed to whatever they want, any changes, how their working environment is. NHS rolled out what we call annual staff survey, which is probably one of the largest workforce surveys in the world. It takes place annually. It's optional for staff, but usually gets a good staff sort of engagement. And again, all organizations then have a responsibility to analyze those survey results and then demonstrate that they have taken action on areas which need further improvement, which need attention, and then they have to report it nationally. How people perceive NHS, the 2019 survey of public issues showed that after EU or Brexit, which is a very hot topic these days in United Kingdom, NHS hospitals or healthcare is the next most important issue which people talk about, think about, because as Professor Adil mentioned, since its inception in 1948, NHS has stuck to its basic funding principles of providing free care to all at the point of entry. And that is something public values hugely, and it becomes a very important issue in every election, that people value it, people want to keep it, and they acknowledge the benefits NHS provides. And that is, as mentioned, that has been the situation for many years. If you look back over the last about 15, 20 years, it has always been rated very highly with the public. And to make sure this is maintained with a staff of 1.6 million, it's an absolute requirement that NHS then looks after its staff through all stages of their life, from whether it's like starting the job, parenthood, deaths, old age, and it is it becomes what we call a caring or a good employer, because NHS is a human enterprise. So that's the response we get from public, is primarily public values the service they get, and they basically come to hospital to see people. So they value the people in the NHS and the care they get from their people. And recent COVID pandemic has been a perfect example of that, where people have been massively acknowledging NHS for its contribution in handling the pandemic and the quality of care they have provided, despite financial challenges and limitations in resources. It has been highly valued by staff. In terms of how the future looks like, I think if there is a huge shortage of staff, because working in healthcare, just like working anywhere in the world, is a very challenging, complex environment, and hiring the right workforce and retaining them is always a challenge. At the moment, NHS is facing a shortage of around 100,000 staff, and it's projected to increase in next 10 years to about 250,000. It is a huge challenge, and if we link it with the amount of money NHS spends on staff, approximately 70% of its budget goes in what we call staff costs. It's a huge financial investment. It's a challenge to maintain that. So just like any other organizations, any other systems in the world, NHS is also looking at ways how it's sustainable. Can we look at different working arrangements for staff with their engagement, but with upskilling, and how we maintain staff retention and then sort of keep the workforce. So it is a big challenge, looking after 68 million population with, as Professor Adil mentioned, with about 1/5 of those above 65s, and with a national financial crisis since the recession of 2008, it is a big challenge. But the key challenge is keeping the balance right, so not downsizing, because as healthcare is becoming more and more complex, there is going to be a rising need for staff rather than reductions in staff member. And the only way NHS can deliver that is by offering a good deal to their staff to make sure we retain staff, we can protect them, we can support them through different stages of their career. So if we basically want them to care for our public, then we need to look after them. And I think if we compare it with the global phenomenon, I know all healthcare systems are struggling, and there is always a strong desire to look inwards to cut costs. And usually most healthcare systems, owing to a lot of spending on staffing, there is always an urge on what we call short-termism sometimes, is to change the terms and conditions, to move into temporary type contracts, and to save money on that. But I think the challenge is, do we save through those cuts, or do we save through innovative ways in terms of upskilling the staff, and then looking at the range of skills they can deliver, and making the best use of technology, how they can deliver the future healthcare service through those systems, and they feel satisfied and happier in the role they play. So I would stop here because I just want to leave some time for question and answer, and then also so that we can then allow time for other channels to merge with us. So thank you.
Thank you, Shafiq. This is very helpful. So I think you definitely made a very good picture that not only we are the 5th biggest employer in the world, the NHS, but they also value them very much. And I always say that staff is always your biggest asset. Doesn't matter whether the health system or other industries, but in the NHS, it is very, very evident that we need to be thinking that staff is the biggest asset. So a couple of questions. You're right that in particular, doctor salaries have been increased. And I remember 2004 consultant contract when the salary had a big jump. But just for sake of our audience, all those salaries, we need to remember almost 40 to 50% of consultant salary goes to tax and national insurance. I showed you the graph which says that where our income is, the UK income is, and where our expenses is. And income, I showed you that most of the income is coming from tax, and then we called it pay as you earn. So all the doctor taxes are being deducted, and we pay almost 40% tax on our salaries. And so it is not like comparing with other countries where maybe there are less tax. So my question is, Shafiq, can you also just talk a little bit about the burnout and productivity? Because one of the challenges we found in the NHS that staff burnout and staff leakage. And second is that by increasing the salary and looking, what's our productivity?
Thank you. I think there are two very good questions. I think first of all, in terms of the burnout, I think as I mentioned, training and developing healthcare workforce is a very labor intensive and finance and resource intensive process because it takes many years to train a healthcare worker. And obviously it takes much longer to train a medical staff. At the moment, NHS has 100,000 staff shortage. It is a huge challenge. And what that means is then the rest of the staff have to pick up the work of that 100,000 people who are not there. And that naturally means they have to work longer hours. And many people who work in NHS, they love their job. They are in that profession, not because of money, but because of the satisfaction they get in doing their job. So they end up working longer hours, helping their colleagues, being there, and that naturally leads to what we call staff burnout. So that has been a key issues in the NHS People Plan, which has been rolled out last year, is to look at the staff well-being side of things and see how we can improve working conditions. And also obviously it's a combination of two things, increasing the numbers of staff, but also looking at the working condition of staff so that we can reduce the burnout, and also providing them opportunities, what we call staff well-being. So where they can get like flexible working arrangements, they get some time off with family, things like that. So there are a number of initiatives being looked into to make sure doctors do not have that, or healthcare workers do not have that burnout.
Thank you, Shafiq. Can I just bring Professor Asghar Naqi here? I'm sure we talk about the workforce here and how they are being acknowledged and taken care of. And with your role and with the role where you are, how are things over there, and some reflections?
Thank you very much, Dr. Adil. Similarly, I was just inquiring about the 70% of the NHS budget goes to the pays and pensions of the workforce. And I think it would be perhaps more than that in our setup. And since the 18th Amendment, health has been devolved. It's now a provincial subject. Talking specifically about Mayo Hospital, the majority of the budget that we receive annually, once again, goes for the pays and pensions. And now similarly, there are 2 or 3 different interventions that are in the pipeline, as you all may be knowing, like having this health card scheme, which Mr. Jishnu has actually spoken a lot about. which is going to be practiced now here. Then the MTI Act, in which there would be institution-based practice, and there would be a composite type of work in which there would be some healthcare coverage by the government sector, some healthcare coverage by the insurance sector, and some out of the pocket coverage. So saying all that, trained human resource is the most difficult human resource to produce, and to give it protected time for professional development, to look after it in sickness and disability and other things, I think we lag far behind. And that is one of the reasons that the burnout rates in our part of the world are perhaps much more than the burnout rates in, let's say, NHS. At this point of time, I don't know whether there are any steps taken to rectify this. The other thing was to improve the quality of service, giving incentives, whether external incentives or having monitoring and having checks or balances about the functioning of various healthcare workers. This thing is going to be practiced more. Is it going to be an incentive, or is it going to be an increased burden resulting in more burnout? That remains to be seen.
Thank you, Professor Naqi. I'm just mindful of time. Maybe we have got 3 minutes. If you're happy, I can summarize the session, but I will start from saying my sincere thanks to my co-chair, Professor Asghar Naqi and Shafiq Gill, and also to the speaker, in particular to Jishnu Das, because I'm sure it is very early morning over there where you are. So thanks for your time and joining us. And I think you did bring a lot of good perspective. And then very, very important, thanks to Abdullah Gujjar. He's been an excellent organizer. I know he kept us on our toes, but I think the success of this session, and I'm grateful for all his hard work. And now, in summary, I started talking about the NHS finances, which says very clearly that we spend almost 9% of our GDP on $4,500 per person per year. And then that's being distributed pretty well. And it is a beverage system. It means that universal healthcare provided free at the point of delivery. We are also mindful in our health system, quantity and quality at the same time. So our finances are being distributed and being checked upon and regulated upon based on the quality, the outcomes. So that is some of the lessons. NHS is not complete. There are many gaps in it, but still it is being seen as one of the best healthcare systems in the world. And there are many things which can be learned from our side. Then Jishnu Das, he did give us a very good start about 2 schools of thoughts, that private insurance versus a public sector, and then the challenges in developing countries, in particular in the public sector, which are not properly regulated, and then you cannot manage the things as we expect. And then if you can bring the private sector on board, then it has got its own challenges. And the examples like admin costs, reimbursement, and then the unintentional variation. But again, the summary of our two different spectrum, two end of spectrum, from the insurance to the public sector, is that it needs to be a regulation, quality, and data. These are the paramount if we want to achieve the quality outcome for our health system. And then, of course, Shafiq Gill talked about the staff is the biggest asset, and the NHS is taking care of it very well. And all the privileges NHS is providing, but while there are privileges, there are certain obligations on the NHS staff we must fulfill. But there are challenges like burnout, their productivity, they're still questionable, and then of course, NHS at times being blamed about the brain drain and poaching. It is, I mean, if you look at the Commonwealth, I think most of the people who work in the NHS, they are coming from most of the Commonwealth countries. 35% of our consultant workforce is from BAME community, and many of them are from overseas. I think with that summary, I will again say thank you to the audience, but I will leave it a big message to you, because you are the leader in the local health system. It is your actions which needs to inspire the change. We are able to give you some ideas being Cancolians, but we are very keen that if there are any further interactions you need with all of us, we'll be delighted. But on the similar note, you need to take those ideas and change them into actions in your own system. Thank you.
Thank you very much, Dr. Mahmood Adil and all the speakers and coaches. We will end this session here.